It's my pleasure to introduce Dr. Hussein Ahmed. He's going to introduce a title, lecture title TE for EPS. Please.
All right, good afternoon. Nice to see you again. So we will discuss today about the TE utility in pediatric electrophysiological studies. Actually, I have none of conflict of interest. Well, first of all, I want to discuss the impact of fluoroscopy on pediatric age group. Actually, there is an increased cancer risk associated with radiation exposure at dose levels that can be received by any a child going into cardiac catheterization. Actually, cardiac catheterization in complex congenital heart disease might be lengthy with excessive exposure. Actually, the fluoroscopy risk depends on the duration, the type of the procedure, actually the machines that you are using for imaging, and the complexity of the anatomy. Actually, you might say that arrhythmias doesn't allow for much radiation exposure, but actually atrial tachycardias, AVNRT and AVRT, actually the procedure time totally might expose the patient to more than 220 X-rays. This is in a child. So actually, to minimize fluorodoses, actually we can use intracardiac echo and 3D mapping system. Actually, this can shift the procedure to a zero fluoro procedure with no radiation risk. However, in a limited setup like us or a smaller child with IF catheters poses a great risk of vascular damage, attempt at reducing the fluoroscopy times is highly recommended. Utilizing transesophageal echo is available in majority of pediatric cath labs and can give the benefit of guiding multiple steps during the ablation procedure and reducing fluoroscopy time. So we can very simply, as Shadi discussed earlier, we can see the catheter position in complex congenital cardiac disease, such as Epstein anomaly, identify the presence of intracardiac shunt, guide the cannulation of the coronary sinus, especially in isomeric patients, and guide transeptal access to the left atrium. We have a lot of arrays for pediatrics. 1, C, and D actually are designed for pediatric population. They are, first of all, they were 2 planes, and now there is multi-planar TE for children. Mike. Actually, that can be used up to 5 kilograms of weight. So this is a very simple example of coronary sinus cannulation in a patient with dextrocardia. Actually, he's a Cartagner syndrome. This is a very simple fluoroscopic images and in fixed images. This is a CS. This is a tricuspid valve, the right atrium, the right ventricle. So this is a video of the patient. Actually, the patient is dextrocardic. So actually, we rotated the entire angle to 180. And this is while we are identifying his coronary sinus. We can see that this is his coronary sinus. Sorry. So this is while we are cannulating the coronary sinus. And this is just for confirmation of cannulation. Actually, exclusion of blood clots. This is a patient who is just exploring his left atrial appendix. It's completely clear out of any clots prior to intervention. Actually, to guide transeptal access, this is very important as it reduces the fluoro time exponentially. Actually, this is while we are trying to position the needle into the interatrial septum. We are advancing the needle. And here we are piercing the septum. And then the needle and the sheath went up to the left atrium. Actually, in older children, we can use real-time 3D echo images like this. This is actually this is the 3D reconstructed images in lifetime, and this is the sheath going into the left side atrium, and this is the right atrium, and this is the aortic valve. So you can see that you are in a safe position. Assess cath stability and position. Actually, this patient was an Epstein anomaly, and we had a lot of problems stabilizing the catheter, even when in 3D. So we decided to go for transesophageal echo and start to manipulate the catheter until we get a good signal and a good stable position. Actually, this is now prior to ablation. So this is while we are ablating. The spontaneous contrast that's happening is that we are using an irrigated catheter tip. So this is saline bubbles coming out of the catheter to reduce the temperature and make it safe procedure. Actually, to sum up, attempt at fluoro reduction or zero fluoro strategy should be attempted in every pediatric population patient during the ablation procedure. However, we have a very limited resource setup. We have small children going now up in ablation, so we cannot use IF catheters. And even if we have it, we will preserve it for patients with ventricular tachycardia, things like that, which we don't see a lot in SVTs. We don't see VTs a lot in children. So TEE might be good, acceptable, and easy to achieve utility to decrease fluoroscopy times. The main problem here is that if you want to do it in a 3D mode, you need a child that's more than 25 kilograms. I think now GE developed a new probe that's called the 9VT 3D probe. This can work up to 5 kilograms, but it's very expensive and not available in Egypt. It was a very short presentation. Thank you.
Thank you so much, Dr. Hussein. Any question from the audience?
I have a suggestion for the next time, just to pick two cases, the same diagnosis, the same criteria, the same intervention. Do one with ICE and one with TE, then compare together live, and we can see the outcome.
A debate.
Yes.
هو صراحة الحمد لله احنا عندنا very advanced cath lab. الحمد لله we have a lot of toys that we can work with. بس اوكي بس ان شاء الله ان شاء الله بكرة بإذن الله.
مش سؤال، هو بس يعني حاجه كده انا طرقت في دماغي. هل لو احنا قارنا ما بين الايس وما بين التي اي regarding الستريسفul conditions اللي هي added على الاوبريتور، لان في another colleague بيشتغل تي اي، حضرتك you are shouting and screaming for him، انت خلاص هو اللي هياخد كل الحاجات. انما في الايس I'm the operator، انا اللي بعمل كل حاجه. فايتس تايم كونسيومر او more stressful conditions I don't know حاجه، بس يعني ما فكرت فيهم الكومباريزون ما بينهم للغاند الستريس والتايم كونسيومينج هتبقى
هو طبعا التي اي definitely time consuming، بس هو actually دلوقتي في options ان انت تبروجكت التي اي ايمج اون ذا فلوروسكوبي وهو شغال، فهو بيبقى قادر يبص على التي اي قدام.
The second operator.
We almost always have two operators, so we have no problem. أنا second operator دايما. Yeah, exactly.
With the ice, you can be frustrated over the fellow. That's not the thing. And yeah, that's right.
You don't need a reason.
My question is there, what is the least ice catheter French? I mean, can we put an 8.5?
8.
8 Frenchies, yeah.
Through a 9.
Yeah, it's
So can
8
we
French,
put,
that's right.
But it has to be 5 kilograms for
No, yeah, 8 Frenchies. I think it needs a bigger child, around 15 kilograms or 20.
So
It's definitely a limitation,
that's
yeah.
where the comparison
For sure.
comes.
Yeah, definitely a
Because,
limitation.
The
Smaller
50
child.
rope for 5 kilograms.
Yeah, it's for 3D echo, but not for.
No, you're right. I think for most of the limitations we have for electively taking somebody to the EP lab as far as size is 15 kilos. Studies have shown that kids that are less than that have higher risk of vascular complications. So they're usually going to be at the age where you can get an ICE catheter in if you need to.
Okay, thank you so much. We'll close this session and I invite the chairperson for the next session. Thank you so much.